Hi, I'm Dr. Stuart Goldberg from the John Thor Cancer Center at Hackensack University Medical Center, and I'm here today to talk a little about chronic myeloid leukemia. This is one of those small population cancers that many physicians will see in their practice, but don't have a lot of experience with. But because there have been tremendous advances in the last decade, it's important to keep up to date on what is the new treatments, because these treatments really can help patients and prolong life and save many patients from the agony of going through salvage therapies. So in the last decade, we've seen the development of the tyrosine kinase inhibitors. Prior to 2000, patients who were young, who had CML, would have been referred for bone marrow transplantation, which could cure them, but also contained significant morbidity and mortality. And older patients, unfortunately, were out of luck. But with the development of the tyrosine kinase inhibitors, we've seen that these oral medications can basically place most patients into remission, and most of these remissions have been long-lived, with patients now out 10 years on these medications. We do have 3 that are commercially available, and choosing between them is still an art. Imatinib has been the first drug, and that's the flagship drug for tyrosine kinase inhibition, showing from the IRIS study back in the early 2000s that patients who received this medication, over 85% of them would go into remission, and that we could see most of those patients becoming long survivors. But unfortunately, about a quarter of patients would either relapse or become intolerant to the therapy, and so we developed 2 new medications, dasatinib and nilotinib. Both are oral, both are able to get about half of the patients back into remission, and most of those patients, again, will do quite well. But there are still a few patients who will fail all therapies and be referred for transplant. Within the last 6 months, we've seen that both of the new drugs, dasatinib and nilotinib, have been compared against our old favorite, imatinib, and we've seen that both of the new drugs actually get more patients into remission early on, and whether they will become the standard for first-line therapy needs to be determined. But I think that one of the things we can see is that the field is changing very rapidly, but it's changing in a very good fashion for our patients. So trying to keep ahead of this curve and know what's going on can be quite difficult for a doctor who only sees a couple patients a year. So programs like this, which are going to be shown on the ACCC website, which is www.accc-cancer.org, can be very helpful for your practice. In addition, I would encourage physicians and nurses and other healthcare professionals to go to the American Society of Hematology and the American Society of Clinical Oncology's websites and look at the educational books. This is especially helpful in rare cancers because each year at the national meetings there's educational seminars, and in those books, which are shown online, you can read a 1 or 2 page summary of what's happened in the last year to keep up to date. Another thing that may be helpful for physicians is to look to see if there are published guidelines on how to treat these. For example, in CML, both the National Comprehensive Cancer Network and the European Leukemia Network continually publish updates on the management of this disease with nice graphs. You can follow your patient. For example, a patient who's treated with these medications and after 3 months still has an elevated white count, obviously the medication is not working, and you may want to consider switching to another therapy. By 6 months, we would like to see some genetic changes, and by 12 months or 18 months, we'd like to see a genetic remission. So putting a flow sheet in the chart with some of the updated guidelines and then following the patient to see that they meet the milestones can be very helpful. When in doubt, though, call a friend. These are rare cancers, but you may have a friend who's an expert. He may be your competition, he may be even outside your catchment area. But picking up the phone and saying, hey, have you seen a patient with this disease recently, and what are you doing? Physicians in general are willing to help other physicians when we know it's going to be best for the patient. So in a rare tumor, don't let your ego get in front of you. Help the patient by calling a friend. Thanks. This is an interesting disease. It's a small disease, but it's teaching us a lot about cancer. And I think by looking at small population diseases, we can learn how to treat the big cancers.